You know that cough, the really deep, chesty one?
Mm.
Maybe with a fever, making you feel awful.
We've all had nasty bugs like that.
Exactly. But sometimes it's a bit more serious, something actually going on down in the lungs.
Precisely. And today we're going to unpack one of the big players there, community-acquired pneumonia, CAP for short.
Right, CAP. We've got some solid revision notes here, and the plan is basically to break it down, make it super clear, high yield for anyone revising this, you're fast-tracked to the essentials.
Sounds good. Let's jump in.
Okay, so first off, the definition. What exactly is community-acquired pneumonia?
Well, fundamentally, it's an acute infection right down in the lung tissue, the parenchyma. And the key bit is community-acquired.
Meaning you didn't pick it up in hospital.
Exactly. You got it out and about, not during a recent hospital stay or if you're living in, say, a long-term care home. It's a very common type of lower respiratory tract infection, an LRTI.
Got it. And it's not always the same severity, is it?
No, definitely not. It ranges quite widely. Some people just need, a cross of oral antibiotics at home and they bounce back.
But for others,
Yeah.
it can be much more serious.
Yes, unfortunately. Some people need hospital admission, maybe IV antibiotics. And sadly, CAP can lead to significant illness, high morbidity, and even mortality in some cases.
Which is why assessing how severe it is early on is so important.
Absolutely. And we have tools for that, like the CRB-65 score, which helps guide whether someone needs to be in hospital. We'll definitely circle back to that.
Okay, definition nailed. What about the causes, the bugs responsible?
Yeah, the etiology. It's a mix, really. Bacteria are very common culprits. The top bacterial hits are usually Streptococcus pneumonia, often called pneumococcus, and also Haemophilus influenza. Think of strep pneumo as the sort of classic pneumonia bug.
Okay, the usual suspects. Then you mentioned atypical bacteria. What's that about?
Right, so the atypicals include things like Mycoplasma pneumonia, Chlamydophila pneumonia, and Legionella pneumophila.
And why atypical?
Well, partly because they sometimes cause slightly different symptoms, maybe a slower onset or less sputum production, and also because they don't always respond to these standard initial antibiotics like penicillin derivatives. You need different drugs, like macrolides, to target them effectively.
Oh, okay. Like that walking pneumonia people talk about sometimes.
Yeah.
Is that Mycoplasma?
Often, yes. Mycoplasma can cause a milder, more ambulatory form, hence the name. Legionella, on the other hand, can be very severe. So atypical covers a bit of a spectrum.
Gotcha. And it's not just bacteria, is it? Viruses, too.
Oh, absolutely. Respiratory viruses are big players. Things like influenza viruses, respiratory syncytial virus, RSV, especially in winter. They can cause pneumonia directly, or they can sort of weaken the lungs' defenses, making a secondary bacterial infection more likely.
So pinning down the exact cause isn't always simple.
No, not always in practice. It can really depend on the patient's age, whether they have other health problems, comorbidities, and even what viruses or bacteria are circulating locally at the time.
Okay, that makes sense. So who is actually more likely to get CAP? What are the main risk factors?
Well, several things increase your risk. Advanced age is a really significant one. Our immune systems tend to get a bit less robust as we get older.
Right. And smoking. I assume that's on the list.
Definitely. Smoking damages the airway's cleaning mechanisms, making it harder to fight off infections. Chronic lung diseases, too, like COPD, asthma, they make the lungs more vulnerable.
Okay, age, smoking, lung problems, what else?
Anything that suppresses the immune system. So that could be medications like long-term steroids, chemotherapy, or conditions like HIV. We call that immunosuppression.
Makes sense. Weakened defenses.
Exactly.
No.
Also, other underlying health issues, comorbidities like diabetes or heart disease increase the risk. And then there are environmental things like heavy air pollution exposure or certain jobs with dust or fumes.
Right. And you mentioned one other thing, swallowing.
Yes, dysphagia or an impaired swallowing reflex. If someone has difficulty swallowing, they might accidentally inhale small amounts of food, drink, or saliva into their lungs. That's aspiration. And that can directly introduce bacteria and cause pneumonia.
Wow. Okay. That's quite a list of vulnerabilities. So let's say one of these microorganisms does get into the lungs. What actually happens then? The pathophysiology.
Okay, step by step. First, the microorganism has to get down into the lower airways. Usually that's through breathing in tiny droplets coughed or sneezed by someone else, or sometimes through that aspiration we just talked about.
So the bug bypasses the throat's defenses. Then what?
Once it reaches the lung tissue, the alveoli, those tiny air sacs, it starts to multiply and invade the cells there. This invasion immediately triggers the body's alarm system, the immune response.
Inflammation starts.
Right. The body sends immune cells rushing to the area to fight the invaders. These cells release chemicals, inflammatory mediators, which signal for more help and ramp up the fight.
But that inflammation, while necessary, causes the actual problems of pneumonia.
Precisely. This intense inflammatory battle leads to fluid, pus, and debris leaking into the alveoli. These air sacs, which should be full of air for gas exchange, get filled up. That's what we call consolidation.
Consolidation, like the lung becoming more solid in that area.
Exactly. And you can often see that consolidation as a white patch on a chest x-ray.
And because those air sacs are clogged.
Gas exchange is impaired. It's harder for oxygen to get into the blood and carbon dioxide to get out. That's why shortness of breath, or dyspnea, is such a key symptom. The severity of the illness often correlates with how widespread and intense that inflammation and consolidation is.
Okay, that links the process to the symptoms really clearly. Now, thinking about symptoms, what other conditions could look like CAP? Things you need to rule out the differential diagnosis.
Good question. Several things can mimic CAP. Acute bronchitis is a common one, inflammation of the larger airways, the bronchi. It causes cough and maybe some sputum, but usually not that deep lung consolidation you see in pneumonia.
So more airway irritation than lung tissue infection.
Generally, yes. Then there's bronchiolitis, which affects the tiny airways, the bronchioles. That's much more common in very young children, infants, and often causes wheezing.
Okay, what else?
Tuberculosis, TB, is a lung infection, but it's usually much more gradual, chronic. Think persistent cough over weeks or months, weight loss. Night sweat's a different picture from the acute onset of most CAP.
Right. And pulmonary embolism. That can cause sudden breathing problems too, can't it?
Yes, a PE, a blood clot in the lung artery, causes sudden chest pain and shortness of breath. It can overlap symptom-wise, but the onset is often very abrupt, and there might be risk factors like recent surgery or immobility, less likely to have the fever and productive cough of typical pneumonia.
Important distinctions to keep in mind.
Yeah.
Okay, let's zoom out again. How common is CAP in the UK? The epidemiology.
Oh, it's very common. We see it across all ages, but as we said with risk factors, the incidence really climbs with age. The elderly population has the highest rates.
And is there a particular time of year it's more prevalent?
Yes, definitely a seasonal pattern. More cases pop up in the winter months.
Like flu season.
Exactly. It ties in with the increased circulation of respiratory viruses like influenza during winter. These viruses can pave the way for bacterial pneumonia.
And that must put a strain on hospitals.
Absolutely. CAP is a major reason for hospital admissions, especially during those winter surges. It puts significant pressure on NHS resources.
Okay, so let's talk clinical features. What are the classic signs and symptoms someone might experience if they have CAP?
The typical cluster includes a cough, often productive, meaning you're coughing up phlegm or sputum, shortness of breath or dyspnea. Chest pain is common, sometimes pleuritic, meaning it feels sharp and worse when you breathe in deeply or cough.
Ouch.
Yeah. And fever, chills, plus general fatigue, just feeling really unwell.
Are the symptoms always that clear-cut, especially in older people?
No, not always. Particularly in older adults, the classic respiratory symptoms might be less obvious. They might present differently, perhaps with new confusion, maybe just feeling generally weak, off their food, headache, muscle aches. Sometimes the main sign might be delirium.
Right, so you need a high index of suspicion in the elderly.
Definitely. And the severity of these symptoms can vary hugely, from quite mild to life-threatening.
And how do we use these features, plus maybe some simple checks, to gauge severity quickly? You mentioned the CRB-65 score earlier.
Yes, CRB-65 is a really practical tool, especially for assessment outside the hospital. It helps decide how serious it might be and where the patient should be managed.
Okay, let's break it down for revision. CRB-65. What does each letter stand for?
Right. C is for new, confusion assessed simply, like asking orientation questions.
Okay, C, confusion.
R. R is respiratory rate. A rate of 30 breaths per minute or more gets a point. You just count their breaths per minute.
R, respiratory rate 30. B.
B is blood pressure, specifically low blood pressure. So a systolic below 90 mmHg OR, a diastolic of 60 mmHg or less.
B, blood pressure low.
And 65.
That's just age. 65 years or older gets a point.
Okay, CRB 65. 1 point for each if present. What do the scores mean?
So a score of 0 suggests low severity, low risk of dying, around 1–2%. These patients can usually be treated safely at home.
Okay, score 0, point home treatment. What about 1 or 2?
Score 1 or 2 puts them in an intermediate risk category, around 9% mortality. Here, you need to consider hospital assessment or admission. The decision depends on clinical judgment, social support, other factors.
Intermediate risk, consider hospital. And 3 or 4.
A score of 3 or 4 indicates high severity, high mortality risk, anywhere from 15% up to 40%. These patients definitely need urgent hospital admission and assessment for potentially needing intensive care.
Okay, so CRB 65, 0 is low risk, 1, 2 intermediate, 3, 4 high risk. Very useful. And there's CRB 65 too. How's that different?
CRB 65 is basically the hospital version. It adds U for urea.
Blood test result. Exactly. A urea level over 7 millimole gets a point. Since you need a blood test for urea, CURB 65 is used once the patient is in hospital where that test is readily available. CURB 65 is great because you can calculate it quickly without needing labs.
Got it. CRB for community, CRAP adds urea in hospital. So if TRP is suspected, what investigations are typically done, especially if someone needs hospital assessment?
Well, the key investigation, especially if there's doubt about the diagnosis or if the person isn't getting better or if you're thinking about admitting them, is a chest X-ray, CXR.
And you're looking for that consolidation we talked about.
Exactly. That dense white area on the film, typically in the lower lobes for CAP, confirms inflammation and fluid in the lung tissue.
Okay. What about blood tests?
We'd usually do a full blood count, FBC, that can show signs of infection, like a raised white cell count. Inflammatory markers like CRP, C-reactive protein, are also useful.
Yeah.
A high level suggests more severe inflammation.
Right. And blood cultures.
Yes, very important, especially for anyone being admitted. Blood cultures try to grow the bacteria from the blood to identify the specific cause. Ideally, you take these before starting antibiotics as possible.
Okay. Any other samples? Sputum.
Yes, if the patient is producing sputum, sending a sample for culture and sensitivity testing is really helpful. It tells us what bug is in the sputum and which antibiotics will kill it.
And sometimes tests for specific viruses or atypical bacteria.
Yes, particularly in more severe cases or during outbreaks, respiratory viral PCR panels can identify viruses like flu or RSV. And if Legionella or Mycoplasma are suspected based on the clinical picture or risk factors, specific tests like urinary antigen tests for Legionella or serology or PCR for atypicals might be done.
But for someone managed at home with mild CAP, you might not do all of that.
Correct. For low-severity, community-managed CIP, often it's just based on clinical assessment, maybe basic observations like temperature, respiratory rate. A chest X-ray might not even be needed if the picture is clear and they respond quickly to treatment. The investigations really scale up with severity and the need for hospitalization.
Makes sense. So let's talk treatment. Management. Antibiotics are key, right?
Absolutely. Antibiotics are the mainstay. The challenge is choosing the right one initially, as you often don't know the exact bug straight away, so we use empirical therapy.
Meaning a best guess based on likely culprits.
Pretty much. We choose antibiotics based on the patient's severity score, like CRB 65, local antibiotic resistance patterns, and whether they have risk factors for specific organisms.
So what are the typical empirical choices? For low severity, CRB 65 score 0, treated at home.
The standard first choice is usually oral amoxicillin, typically 500 milligrams 3 times a day for about 5 to 7 days.
Okay. And for moderate severity, CRB 65 score 1 or 2, maybe needing hospital assessment.
For moderate severity, we usually need broader coverage. So often it's amoxicillin again, maybe given IV initially if they're in hospital, or higher dose oral, plus a macrolide antibiotic like clarithromycin or azithromycin.
Why add the macrolide?
To cover those atypical bacteria, Mycoplasma, Chlamydophila, Legionella, which amoxicillin doesn't hit well. The course is usually a bit longer too, maybe 7 to 10 days.
Right. And for severe CAP, CRB 65 score 3 or more, definitely in hospital.
For severe cases, we need broad-spectrum intravenous antibiotics straight away. Often that's co-amoxiclav, amoxicillin plus clavulanic acid to overcome some resistance, or another broad beta-lactam like ceftriaxone, again combined with a macrolide.
So IV coamox plus a macrolide typically.
Yes. And then once the patient starts improving clinically, is stable, maybe fever settling, able to eat and drink, we can often switch them from IV to oral antibiotics to complete the course.
Okay. And besides antibiotics, what about supportive care?
Crucial. If their oxygen levels are low, hypoxia, they need supplemental oxygen via nasal cannula or mask. Fluids are often needed, especially if they're dehydrated from fever or poor intake, usually IV fluids initially if they're quite unwell. And managing fever and pain with things like paracetamol or ibuprofen helps with comfort.
Makes sense. What about follow-up after they finish treatment?
Good practice is to review them about 6 weeks later. This can be done by the GP or in a hospital clinic, depending where they were managed.
And do they always need another chest x-ray?
Not always, but it's often recommended, especially if symptoms haven't fully resolved, if they're over 50, or if they smoke. It's to make sure the consolidation has cleared and there isn't an underlying issue, like a tumor, that was hidden by the pneumonia.
Right. Important safety net.
Yeah.
And prevention. Anything people can do.
Yes, vaccination is key for prevention in high-risk groups. The annual flu jab is important, as flu can lead to pneumonia. And the pneumococcal vaccine, PPV or PCV13, depending on age and risk, protects against Streptococcus pneumonia, that's common cause.
So who should get those?
Definitely recommended for everyone aged 65 and over, and also for younger people with chronic health conditions like lung disease, heart disease, diabetes, kidney disease, or weakened immune systems.
Okay. So thinking about outcomes, the prognosis, what does it depend on?
It really varies. Key factors are the patient's age, their general health beforehand, any comorbidities, how severe the pneumonia is when they present, and crucially, how quickly they get the right treatment.
But most people do recover.
Yes. Thankfully, the majority of people with CIP recover fully with appropriate antibiotics and supportive care.
But it's the severe cases we worry about more.
Exactly. Severe CIP, especially in older individuals or those with multiple health problems, carries a higher risk of complications and, sadly, a higher risk of death. Early recognition and prompt treatment really do make a difference to outcomes.
You mentioned complications. What sort of things can go wrong?
Well, the pneumonia itself can lead to respiratory failure, where the lungs just can't cope with oxygenating the blood properly. Sepsis is a major risk. That's when the infection spreads into the bloodstream, causing a whole body inflammatory response, which can be life-threatening.
Scary stuff. What else?
You can get fluid building up around the lung in the pleural space. That's a pleural effusion. If it gets infected, it's called an empyema. Sometimes a lung abscess can form, which is like a pocket of pus within the lung tissue itself. And in the most critical cases, patients can develop acute respiratory distress syndrome, ARDS, which is severe lung injury requiring intensive care.
And these complications often mean longer hospital stays and more intensive treatment.
Definitely. They might need things like chest drains for effusions or empyema, prolonged antibiotics, and potentially ventilation support in an ICU for respiratory failure or ARDS. And having severe pneumonia can also worsen any underlying chronic lung conditions like COPD and sometimes lead to longer-term breathing impairment.
Wow. Okay, so that's a really thorough run-through of CAP, from the definition and causes, through risks, how it develops, how it presents, the scoring systems like CRB65 investigations, and then management and potential complications.
Yeah, it covers the key areas. It really highlights how CKP is common, but exists on a spectrum from relatively mild to potentially very severe, making that initial assessment and prompt action so vital.
Absolutely. And thinking about it all, it really makes you consider, doesn't it, what factors beyond just catching a bug make someone more susceptible? Lifestyle, underlying health, maybe even things like air quality, and the constant background worry of antibiotic resistance influencing our treatment choices.
It's a complex interplay for sure, and emphasizes the importance of prevention, like vaccinations and responsible antibiotic stewardship.
Really important points. Well, if you listening found this deep dive useful for your revision, definitely check out passthemsdr.com and also freemsra.com for loads more resources.
Great resources for MSRA prep.
Thanks so much for joining us today as we tackled community-acquired pneumonia.
My pleasure.